Yeah. So good morning, everyone, and welcome to our panel on a subject that I guess my mom is now also an expert, artificial intelligence, but I always also challenge her a bit on the standards and openEHR. My name is Jovan Pavićević. I'm coming from Better. I obviously have a bad sense for humor, but I'm really happy to be here in Barcelona, a city that was always at the heart of the digital health conversations. And today, for our panel, we have three great panelists, as you were able also to hear from the presentations. So first we have Dr. Jordi Piera Jimenez from Catsalut. He is leading one of the most advanced regional health data strategies in Europe, who will give us a view from the front line of the digital transformation. Then we have Dr. Bernhard Geist from AWS, representing the global tech and cloud infrastructure side. And we have Dr. Seref Arikan from Ocean Health Systems that you were able to hear before, one of the leading openEHR experts combining technical depth with practical AI research and implementation. Welcome. I know we have lunch next, so we'll move fast, stay practical, and aim to leave you with some takeaways to discuss. That's yeah, always no pressure, and hopefully we won't go too technical, so you will be able to digest. So let's start. To start us off, I'll ask each of you for a quick take. When we talk about AI and standards like openEHR, what do you see as the biggest opportunity, but then at the same time as the biggest risk or a biggest challenge that we would need to overcome? And we can go Bernhard, Jordi, and then Seref.
Yeah, I can start. This is super old school here. So let's start with what is the biggest opportunity. And I would say get AI technology in the hands of end users. And Seref was talking a lot about stakeholder and stakeholder management. And I would say the good news is this technology has reached a level of maturity when it comes to end user interaction, where you can really go and say, put it in the hands of people. And you will, as Seref described, you will learn a lot from that. You will learn what works and what doesn't. So be skeptical about what it delivers, be open-eyed about it. But the very moment you do, it does a lot of things. And I can tell you I'm doing the very same thing myself because I'm in the funny situation that I know about clinical IT, I know about the clinician's world, and I'm a patient myself. So the very moment I go to a doctor and I'm a patient, I have exactly 8 minutes with this doctor. And how to make these 8 minutes most meaningful means I prepare for that after agreeing with him that I will be his prompting expert because he's not very tech-savvy. And that changes our interactions a lot. So, and that's my point, bringing AI technology into these meaningful patient conversations, and it changes that a lot. Talking about blockers, I think we have, when it comes to healthcare professional, a lot of acceptance struggles, and I totally understand that, because they don't want to move from being a practitioner to being a supervisor. And especially the very moment that the whole mainstream press goes off about, oh, these models hallucinate and things like that. Yes, if you ask a large language model about very specific medical things, it will hallucinate here and there. That's part of the technology. And that changes a little bit the way they would like to work with it, because they say, oh, I don't know, can I trust this thing? Yeah. And so acceptance is a big thing. It has to do with trust, but it circles back to my first statement. Bring it to the hands of people, and they will tell you how they work with it, and you'll learn a lot. Thank you.
Thank you. Jordi.
Thank you for the question, Jovan. I fully agree with Bern. I think that, and maybe continuing off on his point, I think that in order for us to be able to give the right use to these solutions and to bring them, I mean, the time to market of them to be reduced, openEHR can be a big lever into this, coupled by something else possibly. So we need to agree or find a common way so everyone develops in the same way. But I think that it's, for me, the two main points or the biggest opportunities is time to market and real use of such solutions, which, as I mentioned before, in our ecosystem, we are really slow. And then, well, sustainability or money savings. I mean, it doesn't make sense to spend 60 to 90% of our time in each of these data products, understanding the data, retraining the data, looking for the quality of the data, and redoing the same thing again and again. It doesn't simply not scale up. So I believe that this could be, for me, the two biggest opportunities. And then as a barrier or as a blocker, I believe that it's the enemies of setting data free. And I said that they are not in this room, and I believe that they are not in this room, but they are outside this room. And they sit on the data, and they just provide here and there some small interfaces in which we can do things with this data. And they are very powerful, and they are fully embedded in day-to-day operations and care processes and pathways in very big organizations all across the world. So this will be a tough fight against these blockers.
Seref?
Thank you. So I think we should recognize the fact that the value and the growth and the current and hopefully growing success of openEHR depends on the fact that it is driven by clinicians more than anything. So if you're a technical person who's coming into openEHR, just saying, leave your ego at the door, because what we're trying to do here is to get clinicians have control with the very little time they have. And this has been our biggest problem. We never had any shortage of, software developers and brilliant minds interested in solving these challenges. Where we have the challenge is just finding another use or SAM or header, because if you look at the numbers, they are extremely rare. So the number one opportunity I see is using large language models, specifically, as a community multiplier of sorts that makes it easier to get contribution or input from clinicians, that we use it to lower that barrier for them so that they can engage and they can give us feedback and set directions. And there is an inevitable amount of just complexity in healthcare, and that is reflected on the technology side of it. So the more we can do to get our clinical champions, a term David Ingram coined, the more we get the clinical champions engaged, the faster and stronger we're going to go forward for good outcomes for all of us as patients. The barrier, I think, the biggest one is the huge hype, creating an uncertainty and lack of understanding in exactly what AI is, because it is defined in so broad and so loud, so, just big terms that it's leading to a paralysis where we're all just sitting here and waiting for AI to come and save us from, all our mundane struggles, but that's not going to happen. So I think the barrier is getting a minimum but sufficient understanding of what the options are in the AI space, which ones can help whom, doing what, and starting, just a roadmap that's, based on that mapping. So some clarity, I think, will be very helpful unlocking the barrier as I see it. Thank you.
Thank you for the openings. So we see that more or less every conversation about AI comes down to the data, right? And we see the projects, many of them promising this transformation, creating a big hype, but without the quality data, they usually fail apart also. So let's maybe first start as a first topic to talk about this foundation for the AI, the data. And AI, we know that it thrives on the big amounts of data, where in healthcare we maybe need a smaller amount, but really precise and with a good semantics. And there is a big kind of a a balancing act between the two. So Bernhard, maybe for you first to tackle this, from your experiences, what you are doing at AWS, how do you see organizations are actually making this balance between, okay, we have a massive data need here, but at the same time we need precision and semantics?
Yeah. Let me start with saying that one of the good things is, and I talked about maturity, is that the maturity of our tooling today is so good, and the barrier is so low that we can now really focus on content and data structures, actually. And that's an important thing, because there have been a lot of fiddling around with how can I do that, and how can I run a model, and all these stuff. Come on. I mean, you can just take a model of Hugging Face, and we just heard about the 100,000s of models that are there, throw it on Amazon Bedrock, and it runs, and it's about 30 seconds. And even if you go and try to build your own model, you can just take SageMaker and really look at, do I have the right data? Is there bias in the data, and other things? Is it overcoded because it's influenced by billing things? These are the things we need to look at. These are the things we really need to do. And openEHR and semantically correct data is the only way to do that, the only way. And the beautiful thing is that even AI can help us with that. So we are building solutions with partners and proof of concepts where we go and say, here's a patient conversation. We use AI to convert this conversation to medical entities, and then use AI to fill out an openEHR form based on a template. And even use another agent that does the quality checking. And agent 1 is rejecting what agent 2 is doing because the quality was not good enough, and agent 1 has then to do another run. That's possible today. And I mean, we even open sourced that. Yeah? So it actually takes 3 lines of Python language. Yeah? From strands, import agent, you make a new instance, and off you go with an agent framework. So what I'm trying to say, we have all the tools. Yeah? No stress there anymore. Let's really go there and make sure that data is meaningful. And if we do medical research on large-scale data, you need large-scale platforms. And that's what we do at AWS, and try to help partners there. And last word on that, let's keep in mind that we have transformer models. All our LLMs are built on transformer technology. Transformers are fantastic at finding patterns. And that can be so much better than doing regression analysis, is what we are doing on large-scale studies. And if you kind of tokenize medical data, run a transformer model over it, your eyes can be big, what you find there. So this is coming, together with agents. So much looking forward to that. So happy to support our partners on that. Thank you.
Thank you. I'll ask this maybe a bit controversially. I mean, not directed necessarily to openEHR, but standards in general, they are sometimes blessing and a curse, right? So they have their pros and cons, and openEHR gives us this, we have the reference model, we have the archetypes, we have templates, so really nice stack of governance tools, if I may call them like that, that can give us this semantic consistency. But Seref, maybe to you, it's a bit more technical also. Do you see this maybe as something that could slow us down in this AI path, or how would you comment it?
Okay, that's a fair question. So one, and I'm sure you've seen it, I mean, Bart demonstrated in the morning, one example of very, just loudly made public is you feed some input to artificial intelligence and it gives you back software. And that is exactly the kind of, let's say, trend that we're seeing, that, everybody's just building, just solutions and startups, et cetera, et cetera. So I have just a humble observation, which I share with my friends all the time, especially on the technical side of things. And I keep saying, healthcare breaks everything. So, vendors arrive with technology, they arrive with plans, blueprints, this, that, they're proud and loud, and they walk into a room, and 2 months down the line, they're like, we've never seen that, do that before. We never thought it would be this deep, that much, etc., etc. So I am not entirely convinced of the large language models just presenting an alternative to semantically precise models that reflect the requirements of a clinician. What is happening, on the contrary, I think, is the large language models, again, we're talking about a specific type of AI, they are incredibly good at consuming data given in a concise format. So here's a sneak peek. The questions you saw, some of you, were here earlier in my slides, I actually took the knowledge dump, the templates and archetypes from Ocean's infection control solution. Then I fed them to an artificial intelligence along with some documentation about openEHR specification, and I said, get me the most likely questions a healthcare professional would ask for population-related concerns. And it gave me 30 questions, and I said, add the information I would need to answer to these questions. So 3 of that 30 was on the screen, but I took them, then I sent them to Ocean's infection control professional, who is the domain expert, and I said, can you please do, just a reality check here and tell me, because I used AI. Desley, she went through them and said, nope, these all check. And the reason that checks is instead of going to a direct chat GPT window and asking the same question, I provided the actual openEHR models as the context. This is why I was talking about it as a skill. And these are concise representations of the clinical concepts, and it then delivered very high quality output. Now, compared to someone sitting there and saying, write me an infection control system, you tell me, am I going faster or are they going faster? So there is a way to use this that eliminates the threshold. Look, when you do openEHR, you're always earning in the long term. But the problem is it takes more time in the short term, and you all have political pressure and software delivery pressure on you. So it's difficult to say, well, this is going to be really good in the future, because now it's just putting pressure on your back all the time. You use openEHR with AI, you deliver the quality outcomes much faster than the prompt engineering guy. As far as I see it, that's a huge, huge potential. So I think it will be much better, actually. Yeah. Thanks.
Very, very good point. Thank you. Jordi, you said before money needs to follow the strategy, right? But there is some money. So the question for you is maybe when it comes to this discussion, okay, data, quality of the data, AI, piloting AI, where do you put your money first at the moment? Is it cleaning the data or piloting and then?
Well, now it's a difficult decision because, as I said, the world doesn't stop spinning around, and you cannot put fences to innovation. So basically, we are doing a lot of pilot projects and even real life procurements after the piloting, procuring some of these technologies to be fully embedded in our ecosystem. In digital imaging, for example, we have procured what we name an inference platform, which will be the one and only hub to connect all the different algorithms that relate to imaging, digital pathology, and omics data. And this is an ongoing procurement in which we will plug this in. And also some ongoing contracts or tenders in which we are procuring this type of solution. So this is something that we are doing on one side because the world doesn't stop spinning and we need to provide things to the ecosystem. Plus, politicians, they like these shiny things and they want their medals. We cannot tell them, no, now you need to wait until all of our data stack is openEHR native, and then we will be able to plug everything very beautifully on top of this. So I would say that it's a hybrid approach. We are investing a lot in rebuilding everything from scratch, in trying to save as much as possible data from our legacy systems and export or import it in our clinical data repository openEHR native, and it's huge investments in this, but then we continue to put some of our capacity to invest in things that we believe that will add value, and with a very strong focus in the imaging part, that we know this one is, well, quite stable, so to say, other than the ones that are built in clinical data, which is not normalized.
Thank you, Jordi. So let's come back. You mentioned before also a bit the hype around AI, and we are for sure living a hype of AI at the moment, because wherever you go, every conference, every place, literally it has AI inside, AI inside, AI inside. But we see that the results of this AI output can be quite uneven. And Seref, you also mentioned before a bit, and you had a nice slide with a different topic. It says the wall of reality. So I'd like to paint this wall of reality maybe. And if you would have to, decide, how would you help health systems, health organizations to make a difference between this, what AI can deliver today and what's still maybe in the norms of illusionary?
So I'm going to fall back to what Professor David Ingram taught me, his motto, implementation, implementation, implementation. In my slides, there was just one item in one slide that was written in the first person. Everything else was written as we, but that one began with my. So I was just doing my best, trying to share something I learned after, making a living 28 years from software. I'm not saying I'm good, but it's just that I survived for 28 years. So the single most important skill in technology is, in my opinion, delivering from day one without cornering yourself, without painting yourself into a corner in 2 months. The whole expertise, the skill, all of that comes down to beginning quickly delivering something, testing all the avenues, but without ending up as excuse the term, short-term hack that then says, oh, sorry, we can't scale, or oh, I didn't think about that. And so the same principle applies to adopting artificial intelligence. Earlier I mentioned that just a lack of clarity. So for me, it's all about finding the stakeholders, asking, starting not from a solution that's looking for a problem. If anybody remembers blockchain, you know what I'm talking about. But starting from problems, talking to real people, stakeholders, then mapping that to the capabilities we have available to us, and start implementing, and easily, just not having any emotional attachment to any software or technology, just crossing it out, saying, okay, not working, not yet. This one's promising, all right? But there is obviously a lot of engineering and planning and principles you learn and adopt in this space, like I have done, like all the other vendors have done. But we can scale this without sacrificing, future. So I would always fall back to, let's start with an implementation, see which problems we can solve, and focus on the ones we have most promise. But without playing with these things, you and I will keep watching presentations with fancy slides, with a lot of diagrams, but we need to see the value, and the only way to do that is to get our hands dirty in a controlled way. Yeah, thank you.
Well, the good thing in healthcare is that we have a lot of problems, so we can pick from which to start and implement, right? Bernhard, to explain maybe on this, and you've mentioned before also that the tools are mature, so how do you see, what's the right way to match these AI tools to this healthcare problem and healthcare needs, and what are the practical examples that you have from your ecosystem?
Yeah, to simplify for builders to use AI both in a model-driven or an agentic frame setup, we actually put together an AI framework for healthcare. So there's a AWS-backed initiative to build AI-driven healthcare systems, and we have built an initiative around it. There are a number of things. We have open sourced, so you can just go to GitHub and look at strands at our agentic framework. We have open sourced agents for healthcare that you can find and just download from GitHub. So there are building blocks you can use just to start off. You asked about practical examples. Let's talk about that. There are so many, so I quickly have to sort which one to pick in a matter of time. One that comes to mind is from Ireland. The biggest insurance company in Ireland has built has an absolute fantastic data scientist team, and they have built together with us an internal tooling that, and Ireland is the place where we have a national EHR project going on based on openEHR. So they have built an internal reporting tool, which is sounding less great than it actually is, because it offloads all the technology struggles from the end user, stakeholder again. It consists of a number of agents with an orchestrator in the middle, and it plugs into everything it can find from the patient documentation, from their internal knowledge base, and from relational data. So you have agents that live produce SQL statements and kind of research, pull out this data. It's quality managed. They're quality manager agents that, as I said, reject until it's okay. And that means the end user doesn't have to kind of go in all these systems and retrieve data. They get one consistent result, which speeds up a lot and makes you can focus on actually your workflow. That's just great. A similar example that I really love is Collective Minds in Sweden. This is a platform where radiologists and experts on imaging can come together and discuss unclear X-rays, all sorts of X-rays, MRIs, you name it. And one of the problems we faced was that in many X-rays, there is patient-identifiable information as part of the image. And that blocks you completely for sending that around and have other experts kind of having a second, third opinion on it. So we did it together with Collective Mind. We built agents that can remove that. That sounds simple again, but it's a block. Yeah? If you have PII in this X-ray, you can't have another guy looking at it. So agents go, remove this PII, and then you can kind of send it around in an anonymized way, and you get another expert to look at it. Yeah? We have Hopper, which is an AI service that can query against your X-ray, and you can then take the results and move that into an openEHR template and things like that. So, just 3 examples that came to mind.
The shiny examples Jordi's politicians need, right? You said it, so I'll actually expand on this topic. So how do you manage these expectations? So you have probably, well, shiny things from politicians' pressures, maybe there's some also clinical expectations, you know, and you have this time to value opportunity, but the reality is not that. It's much, much more slower. So how do you manage this on your level?
Well, yeah, it's an art. We name it in here the gypsy charm. And I don't know, I mean, we do our best at the end. I think it's a mix of, providing value and going to Seref's point before. I mean, you need to deliver, and you need a continuous pipeline of delivery of things. And what we try to combine is, well, trying to fix things from a data perspective in the foundation of our information systems, while at the same time adding value to the ecosystem. So right now, they want, I mean, one of the big dramas that we have, just to put you an example, is our primary care GPs having very few time to deal with patients. This is because, well, they have a lot of pressure, and one of the reasons is that they are doing a lot of bureaucratic activities instead of caring with patients. So in there we are putting a lot of effort, and this is something that, I mean, gaining physician time for them to care is, and then physicians being happier of having less pressure is something that, that politicians also love. So what we have done is 2 different things on there, just to give you a couple of examples. One is using such tooling in order to decide proactively whether you are entitled to see your GP, or maybe you should be seeing the community nurse, or even some admin staff. And this depends basically on two things. One is your multimorbidity status. In here, we've been able to develop for many years an index, a complex index that defines how healthy are you. And with this continuous index, we know, or we have learned over the years about certain thresholds that make you a healthier or a more complex patient in front of others. So depending on the motivation of the consultation and depending on this multimorbidity index, we decide automatically on patient flows. Patients cannot decide, the GP cannot decide, no one can decide. It's now an algorithm that is deciding whether to organize these patient flows. And with this, we are reducing pressure on our clinicians. And then I would say that same as everywhere else, another big problem is clinical documentation. And, well, medical doctors are spending a lot of time behind the screen, writing the clinical notes, Well, we are now piloting some medical scribes that, are helping, in principle, gain time from the medical doctors. Now, the proofs of concept that we have been doing, they are good so far, but, well, we are still not managing them or this data to go everywhere we want into the complexity of openEHR templates. I mean, depending on the complexity of the template, with a lot of nested archetypes, then we haven't been successful there. But we have achieved, saving time from clinicians, which at the end is what our politicians want. So that's what we are trying.
Everyone's. We're a bit short on time, so we'll have to skip the topic that I wanted to discuss, and you mentioned it, Jordi. It's the portability, but we have here today and tomorrow, so we can discuss it during the breaks. So let's maybe go with something more practical, so for the ending. So we have here care providers, governments, vendors. So what would be your suggestion, one single action for them to take within the next months to prepare for this safe transformation towards AI, which is built on openEHR standard? Seref, Jordi, and maybe then you, Bernhard. One thing,
question.
implementation.
No, because it's not so easy for governments to mobilize. I'm very aware of that fact. So I'm humbly going to ask for conversation. Please just make use of this, initial opportunity to meet people, to talk to people, and at least map out a dialogue so that we can all work together on what you're doing. I think that's the smallest action I can ask for without saying implementation, so that we can move on to that phase. But I would like, more than anything, is to just have a conversation, to understand the problems better, so that we can, go to the next phase of working together. That's the most realistic and smallest atomic thing I can think of. Thank you.
I would say that for once in life, let's not make the mistake of trying to push technology top down, and let's try that these solutions are really driven by real world needs, and from there, let's analyze which are the options. Let's take from a bottom-up approach, and then it will be better for everyone.
Oh, my answer resonates very well with what Jordi and Seref just said. I would say what we need is skills, and that you had that also in your presentation. So skill up people, that they understand what's behind AI, what can it do, and what it doesn't. And this resonates well with what I initially said, bring it to the hands of people, and let's keep in mind that everyone has AI. Everyone has a mobile phone. And there is some sort of AI on this thing. And we've seen several times in technology, and I'm dealing with that now 42 years, we have seen several situations where end users had more access to new technology than enterprise systems. And that's a driver. Yeah? So let's use that driver And I can't sit here in Barcelona without mentioning Alma and Binpar, what you've been doing. So deliver value to your doctors, offload stress, give them a research assistant, and things like that. And they immediately get, wow, this is what AI can do for me. And then, with some skilling, they understand what is my place in that, and you get better stakeholders. And that drives the whole AI adoption. Thank you.
Thank you for these final thoughts. We have a few more minutes maybe for some questions from the audience, if anyone would like to. Yeah, here.
I'll bring the microphone down to you, Bart.
Thank you.
We're competing with lunch now, so I expect high.
I will make it very short. We did an internal analysis. We only had 380 physicians answering out of the 1,200 that we questioned, but we discovered that over 90% of these physicians are using ChatGPT illegally on their mobile phones in the clinical practice. So they're already adopting AI. They are using ChatGPT, taking pictures of the EMR screens on their private mobile phones. So I've talked to then CEOs and board members about liabilities, and they didn't seem to care about liabilities because look in the past, tell me any case where there was liabilities being used. So Jordi, from your policy perspective and being now responsible in Catalonia, how do you deal with that, and how do you deal with the liabilities of illegal use of ChatGPT? Sorry for this question, but I had to ask.
It's a tricky one, and here again, I think I mentioned before, we have another example on how the consumer market is pushing us. We had the wellness devices that we have not managed to integrate them with our medical records, and now we have our clinicians that they don't have good communication in between their teams within the EMR, and they use WhatsApp, and now they are using all these generic LLMs to provide clinical practice. I would say that there's very few that we can do unless we start moving faster than we used to move in the past, and really being able to bring these solutions to the point of care as soon as we can. Going to your question, and so this is what we can do to fix it. So try to be faster, have a framework in which the adoption of these things can be way faster than it is nowadays. When it comes to the liabilities, I believe that, medical doctors are liberal professionals, and they have, and they are very proud of being liberal professionals, and they also have their liability insurances next to them. I would say that if this is on them. There's nothing that we can do to control their mobile phone, same as we haven't been able for them to control taking a picture of a fancy EHR image and then sharing it with all the hospital 1 minute after. So we cannot control that, and I believe it's their thing, but we need to acknowledge our part of being guilty of not providing them the right tools.
Sure, I would like to expand a moment on that. I think this is a cry for help. Nothing else. It's a cry for help. And we all know that doctors and nurses being creative, trying really to help the patient. I mean, they're not trying to break any rules. They try to use the best support they can have. And I think we've all seen clinical workflows depending on WhatsApp and things like that. Yes, that's not legal, but okay, it's happening. So this is a cry for help. This is actually a stakeholder saying, I need faster support because I already see it's possible. So they're trying to do that. And let's move faster. Yeah? This is exactly what I've been talking about. It's in the hand of people and they would like to see it. So let's move. And what they're doing is, and I like your example, they're using an EHR screen, which means they already have structured data. Good. Now we are using the multimodal possibilities of ChatGPT to kind of convert the data and then put it into a model. It's a wrong model. So let's move faster. That's what I read from this question.
May I?
Any other questions, or are we hungry?
No, it's all right. It's okay. No, I'll just very quickly say, I can see a lot of just people who are younger than me in the room, and it's wonderful to see, the community with more people coming in. So to the people around my age and older than me, if anybody remembers Napster, right? Napster was the original, internet-based music sharing capability, not service. And, starting with Metallica, I think they got sued all the way to oblivion, right? Then what happened is Spotify taking the exact same idea, but then, just turning it into something that's within the guardrails and rules and all of that. So if the clinicians are finding value in something and they're already using it, the alternative is to work on doing something better than what they're using and replacing what we call as feral systems with the systems that actually does that better, so that they use the version we provide. And I don't see any other solution beyond that, because we can't stand in front of innovation if it helps a clinician. Thank you.
Thank you, Seref. Hungry? Good. I am also hungry, and but you know who else is hungry? Artificial intelligence.
Yes.
and Rachel actually sums it up nicely before with this idea: AI is what it eats, right? And openEHR gives us a tool to feed it with the right things, right? So let's use it as a community. Please join me in thanking our panelists, Bernhard, Jordi, and Seref. Enjoy your life, your lunch at the conference in Barcelona, of course. Thank you.